Dr. Srinath Reddy, Dr. Tim Evans, and Dr. Mary Paul Kinney, and ladies and gentlemen. This is an important forum, how global communities contribute to the achievement of universal health coverage as committed in the Sustainable Development Goals. I will answer to the 4 key questions. First question, why UHC? UHC is one of the SDG targets. It is the main driver to achieve health-related SDG. UHC is to ensure equitable access to services by all citizens without financial hardship. UHC is ethical imperative. Its universal principles endorse the SDG value of leaving no one behind. Lessons from the MDG off-track countries clearly demonstrate that health services are often not available. Where health services are available, they are not accessible, in particular by the poor who cannot afford to pay. Where services are accessible, they are often poor quality, poorly responsive, and unacceptable by the users. In contrast, lessons from the on-track MDG countries have shown that services are available, are accessible, are of high quality, and are responsive. Second question, how UHC in Thailand was achieved? UHC take a long march between 1975 and 2002. In 1975, Thailand launched tax finance free care for the poor. This reflects strong commitment by the government ensuring services are accessible by the poor, which later extended to cover the elderly, children under 12. The private sector employees are financed by payroll tax finance social health insurance scheme since 1990. However, the public employees are covered by non-contributory tax finance employee welfare scheme. Now the informal sector, they are covered by voluntary community-based health insurance since 1983, which later on in 1994, government subsidized 50% of the premium. Due to its voluntary nature, this scheme will never cover the whole informal sector. Given this effort, in 2001, 70% of the population was insured. The remaining 30% uninsured has gained political buy-in for UHC, as the last push of 30% uninsured should be quite easy. Window of opportunity opened in 2001. UHC was a political manifesto during the 2001 general election campaign that the government launched a tax finance user coverage scheme which covered the whole informal sector, including the poor. Thailand decided at the last push to squeeze from the bottom by extending coverage to the whole informal sector by tax finance scheme. Other countries apply squeeze from the top by extending coverage to the informal sector and financed by premium contributions. This policy choice will not achieve UHC quickly until all the workforce is in the employed sector. Targeting different populations seems to be a common trajectory, not for Thailand, but several countries also apply this trajectory. It is impossible to achieve UHC dream by scaling up to the whole population in one shot without gradually targeting different population groups. The third question, what contributes to UHC achievement? It is the health delivery system that is the main contributing factors. First, investment in health sector, geographical coverage of district health systems, covering 50,000 catchment population between 1970 and 2002. The provincial hospitals are referral backups for district health system through a network. Second, mandatory health services by all medical and nurse graduates and later extended to pharmacists and dentists. Local recruitment and training and hometown placement of graduates, the financial and non-financial incentives are implemented in parallel. This committed health workforce contribute to functioning of health systems. Third, quality of services is gradually improved and being accredited through a voluntary scheme. Fourth, strategic purchasing. If it is managed well, it contributes to efficiency, equity, and access. It requires good governance and institutional capacities of the purchaser organizations. Fourth question, what are the role of WHO and IDP in relation to UHC? There's no need to advocate UHC today. I think it's time to implement. First and foremost, WHO and IDP must empower the country capacities to be able to set UHC political agenda, policy formulation, policy implementation, and monitoring outcomes. Second, WHO and IDP to support cross-country learning and sharing. The expensive international consultants who fly in and fly out, giving generic advices are not useful. These consultants do not understand the complexity of political, socio-economic, and cultural context and other bottlenecks. It is legitimate and it is an ethical responsibility of government to commit to UHC for their fellow citizens. If government are not committed, why should a country have a government? It is legitimate responsibility by WHO and IDP to strengthen country capacity, country at the driver's seat, and manage their own UHC destination. I thank you, Chair.